Hello there, and welcome back to episode 3 out of 6 on STAR Center Talks Compensation Planning. I'm Suzanne Spear, the Director of Workforce Development here at ACU, and we are just really excited to have you here with us today. So for those of you who aren't familiar with ACU, let me just give you a little bit of background about who we are. We are a national nonprofit, and we really are workforce people here. We're focused on 2 goals: the recruitment and retention of a transdisciplinary team. And really that's the road to achieving those 2 goals. We do a lot of things here at ACU, and you can find out all about those on our website at clinicians.org. But I'm here to talk about a special project that we like to call the STAR Center, which is funded by the Bureau of Primary Health Care as a National Cooperative Agreement, or NCA. So that's the STAR Center, which is Solutions, Training, and Assistance for Recruitment and Retention. And this webinar series is brought to you by the STAR Center, which is, as I mentioned, an NCA funded by the Bureau of Primary Health Care. And we are funded to bring you free, yes, free, resources on recruitment and retention. So, and you can also check out the STAR Center website at chcworkforce.org and take a look at all of the different resources, including the archived webinar series from sessions 1 and 2 of this compensation planning series. As I mentioned, I'm Suzanne Spear, and I am joined by an all-star staff at the STAR Center, Mariah Blake, who's the program manager, and her email is mblake@clinicians.org if you have any trouble getting on at the beginning of this broadcast, and she will be happy to answer any questions you might have. We are also we're led by Allison Abe-Sakura, and she is our VP of Training and Programs here at the STAR Center. And she is not on the line today, but she is a part of our STAR Center team, so I always like to mention her. Feel free to get in touch with us at any time using our emails or our phone numbers or through our website. Just a few webinar housekeeping items today. We are recording, so you can, as I mentioned, you can access the recordings of these webinars on our website, and they will be also emailed to you since you are signed up for this series. Feel free to ask questions as we go along. You can put them in the questions box. We are going to save those to the end, and so you can put those in the chat box, the questions box whenever you think of them, and we'll get them to the end. And then get ready to sit back, relax, and have fun, and learn about some compensation planning. Without further ado, I am really thrilled that we have Curt Degenfelder back with us. He is the president of Curt Degenfelder Consulting, and he is really a guru in all things compensation planning and really just knows his stuff. So we're excited to have him back talking about health center provider compensation and retention philosophy. So without further ado, I'm going to hand it over to Curt. Thanks so much, Curt. You can take it away.
Okay, thanks, Suzanne. And good morning or afternoon, as is the case, to all of you. For those of you who were on the first webinar, I was able to get from the STAR Center some feedback on who was on the call, and I looked and saw that we had a lot of HR folks. So hopefully this webinar will be less technical, less financial, not as many numbers and Excel spreadsheets, and more talking about trends that we have seen both in the external marketplace, and I'm sure many of you are familiar with, as well as some of the solutions that health centers are putting out there, and generally how that wraps up into an overall philosophy on how we get, how we pay, and how we keep providers. Okay, so just some thoughts. I'd like to put some, to get us all level set to start out. Recruitment overall is difficult. What we're finding is that physician recruitment is even more difficult. Maybe NP recruitment is easier. And so one state gave me the example, the State Primary Care Association tracked their numbers, and they said in over a 2-year period, their members had reported recruiting 110 new primary care providers. So, decent sample size. The ratio of NPs to MDs was 10 to 1. So, that's not necessarily the focus of this webinar, but to point out that, those, understanding even the composition of providers we're trying to recruit. And if you find your health center is moving towards an NP model increasingly just out of need, you're not alone. Secondly, what we are hearing and what we are seeing is while there are more NPs, they tend to have less experience than NPs had in the past. So basically, rather than it being an RN who, had 10 years experience and then decided to go, and become an NP, it's people kind of straight out of school saying, hey, let's keep your momentum. Straight out of nursing school, let's take it to the next level. And so we have to recognize, while that may be a solution that we are taking advantage of and that we've used in the past, we may have different people coming in. And we're going to talk a little bit around the end of the presentation about onboarding, because I think that's really important, that especially at the beginning, we meet our providers where they are. So the third bullet, so that ratio of mid-levels to physicians is something we've all got to question, right? How high can it go? In some states, there are regulations guiding it. So for example, here in California, where I'm based, there's a maximum of 4 to 1. So does the model work when it's that high? And we'll talk a little bit at the end of, does the model work clinically, but also are we recognizing if we have a physician who's, overseeing those mid-levels, are we giving them enough time? So dentists and hygienists, also difficult for our dental program. Behavioral health, and again, I'll reflect our own needs here in Southern California. I would add Spanish-speaking behavioral health is really, really difficult. And then generally what the rural health centers tell me is, whereas when we think about compensation, usually compensation is correlated to cost of living. That is, in urban areas that tend to be more expensive, you have to pay more because people have to have somewhere to live. What I'm hearing for providers, specifically in the rural areas, is they often pay more because there's just not a supply of providers and they have to pay extra to get someone to come to their area. So again, that's an area where the script normally on compensation is flipped, and probably the rural health centers on the line already know this. But again, that's something kind of nationwide. So if you're experiencing it, that's not unique, and it's not just your health center. Okay. So the statistics also show that hospitals are now the most active recruiters of providers. So that's interesting that it shifted from private practice. And to me, it really kind of says, well, what is the market? What is the competition? And then what's the mindset that we're going to have of our providers? Private practice, it's really kind of easy to understand that mindset, right? It's kind of, and someday someone will come up with a better analogy for this. In the healthcare field, you kind of eat what you kill, right? That providers are running their own business. They tend to work more hours in private practice. They definitely understand the cost of support staff because that comes out of the practice bottom line, as well as they understand the relationship between their ability to generate revenue and their compensation. That probably that understanding probably doesn't exist in health systems. And it's interesting to say whether or not it exists in health centers. I can tell you from the financial perspective that certainly when we have more productive providers, we can afford to pay the providers more. The grant doesn't, only goes so far, and really, as we talked about in the first webinar, for those of you on it, really we get our revenue from fee for service. So, we look maybe as far as as far as compensation to production or revenue generation, we probably look more like a private practice than we do about a health system. I talked to a recruiting company, and they said 73% of their searches involved some level of incentive compensation based on production. And again, we talked about in the first webinar, one of our points of conflict is visits per provider per day. So they use a scale called RVUs, or relative value units. In that RVU system, the more intense services that you do, the more credit you get for it. And quite honestly, for commercial insurers and non-FQHC Medicare, they actually get paid more. In the FQHC world, we don't really, most of our revenue does not come from an RVU basis. So it's kind of less important to us. So if you're using visits rather than revenue, I think that's appropriate. However, just the one thing that I've noted is not using RVUs makes coding less important. So because it doesn't, you get the same credit per visit, regardless of what code or codes you use. And so often community health centers have poor coding. And that's something to think about, other ways to ensure our providers have good coding, or other ways to incentivize good coding. They also reported that 39% had a quality component. And what I just wanted to point out here was everybody talks about quality, but when it comes to pay out money, you see productivity, with a 2-to-1 edge there. So, as far as how we get paid. So just something to keep in mind. The next bullet, probably you've all learned this. It used to be, so I've been doing this since 1996, and way back in the day, some health centers said, well, we don't pay our people very much, so we don't expect much. That strategy no longer works. It doesn't work, quite honestly, financially, but it also doesn't work for retaining people. And, when you're paying at the bottom of the market, just imagine who you're going to get. So when we talk about that philosophy, that compensation philosophy, for some health centers, that's something I've seen that's changed. CHC hours and call, or not having to do call, may be a competitive advantage. And we have to, it says many providers are also looking for less than full time. A great number of providers are looking for less than full time. So I can speak, I know we don't have a lot of operations people on here. I know your operations people don't like, the 4-day-a-week and 3-day-a-week providers. It makes it harder to do the schedule. It makes it harder to achieve continuity of care. It's not great for many reasons, but that's what the providers are looking for. So again, we'll talk later, that's maybe an area of flexibility where a big health system doesn't have that same level of flexibility. And then lastly, the recruitment agencies seem to be much more active in the past. I mean, they're just out there, they're quite on, as the FQHC marketplace has grown, they're actually active all up and down the line. They call me all the time and say, hey, Curt, do you know anyone who's looking for a CFO job? So, so they're very active in our space. They kind of design a package of what they, what they tell the provider. So they need both sides of the equation. They need kind of providers to sell, and they need, healthcare employers to buy. And so they tend to make a package. If you're using one, what everyone tells me is you can't just tell them, well, go find me someone. You got to put your parameters out there. Otherwise, what often happens is they come back with, numbers or a situation that's just not realistic for you. So this is not to say that you shouldn't use recruiters, but just recognizing that they're very active in the marketplace, and they have an impact both on provider expectations as well as, can potentially be a tool for you. Okay, so I always like to give just some examples. I talk to a lot of people. So the first set of bullets is an example, 216,000 base for a primary care provider pegged to the MGMA annual increases, so not by 3% or MEI. Whatever the MGMA does a survey every year of provider practices, and they have a lot of stuff in that survey, but one of the things is provider compensation. So they base it on that increase, and this base is a couple years old, so I bet it's higher. 15,000K signing bonus, 38K annual corporate retirement for the first 2 years, with 22K, K is 1,000, additional to a 401K. Well, there the K is not 1,000. 401K is the retirement program. And what's real interesting in 22,000 is that is above the IRS tax exempt amount. So I believe it's like $18,000 this year. So they're paying them above and saying, look, I guess as financial people always, jump up and down when we see something that's tax inefficient. So we're willing to pay you to be tax inefficient, even if it's tax inefficient. So that tells you about the state of the market. Full family. So I want to circle that word family, medical, life, disability, and insurance paid, and then a guaranteed defined benefit retirement program at 75% of salary if they retire out there. So that is a pretty rich package. The second one, just new residents, and again, this is a couple years ago, 180K right out of school, base, sign-on bonus. So that's what they're paying. The hospitals are offering 200K, 200,000 with a 25,000 to 50,000 sign-on bonus, and she characterized it as brutal competition. What I'm also hearing is that some health systems are now going up the pipeline and paying primary care residents in their PGY, so program year 3. So they do a 3-year program, and then if they're just going into primary care, they're done. If they're going into specialty care, they have to do a fellowship or something like that. But they're getting them while they're still a resident. And paying them, and residents don't make much money and they have school debt, so $50,000 of cash is going to be really meaningful to a PGY 3. So one of the things is, well, if we're recruiting people out of school, right out of school, some of them may be taken. Recruiting people right out of residency, some of them may be taken before they even get out of residency. So again, kind of a tough place to be, and very intense competition. This is not a suggestion that you do that. And again, there's some legal questions that I have about this as well. Certainly wouldn't use grant funds for that. And I don't even know that you could use that. Let's say if you do a cost report, I don't think you could use, potentially you couldn't use that as an allowable cost for a cost report. So if you're saying, well, I got to get in on that, I think you need to have a regulatory and legal discussion, just to say where is your flexibility there, and are there any limitations on what you can do. Okay, so we do want to get mission-oriented providers, but generally we compete against the market. And I always say this is maybe a little easier to think of, let's say at the MA level, right, the medical assistant level. Can you really tell someone who's making $1 above minimum wage at your health center that they, and maybe they have kids, maybe they're caring for other relatives, maybe they have problems making rent? Can you really tell them that if they have an opportunity to get a raise of $2.50 an hour that they shouldn't take that job? Probably not, right? And it's maybe even good for the community if they're paid more. Same thing with providers. There's some threshold, and I like doing spreadsheets and stuff, but I don't know what that threshold is. Some threshold, above which you'd say, gee, it's really hard for me to say missionally that, you should turn down all that money, even though it's going to benefit your family and everything else. So we definitely want to still recruit mission-oriented providers, and we're going to talk about that. And they tend to stay, they tend to be happier, they get a lot of satisfaction out of serving our population. But, not everyone comes in with that focus on the mission. Provider perception of average compensation may not be accurate. What that means is, so I'm here in LA County. We have Kaiser here in LA, and I would say that pretty much every physician who I've ever asked knows what Kaiser pays. So, they know someone who works there, someone who's gotten a job there, they had a conversation about it. So there is a perception, right, when we talk about our larger employers in your own area. It may be, the county health system, it may be if there is a university health system. Since these are large organizations, our providers, hear about what they make, and I don't know if there's any studies on what impacts, people's memories, but generally I find that they tend to remember the highest number, not the average number. So, or that might be a really experienced provider, or might be a very productive provider. There might be other strings attached. So just keep in mind that, if you're doing salary surveys, if you've got some data, just keep in mind, remember when I talked about meeting our providers where they're at, this may be where they're at as a starting point. So the next bullet, I think is, as I've observed, an important part of our compensation philosophy, which is, so I would say that the typical health center fringe benefit rate is somewhere around 22%. Okay. I would say that the typical health system rate is more around 35%, and the typical governmental entity rate is more like 40%. Now, just one caveat on how the numbers work. That includes payroll taxes, some of which are capped. That includes health insurance, which is the same amount for every employee, kind of regardless of how much they make. So a provider's fringe benefit percentage is going to be lower than the percentage of other employees. So this is kind of an organization-wide average, not a provider average. So it's important to understand that if you're running the numbers. But those organizations tend to have higher fringe benefit rates, and it's really difficult to compete on those fringe benefit rates because partly just for the simple note that For the most part, I would say, and you can think about how this works in your own health center, most of the fringe benefits, everyone gets the same, right? So health insurance, we don't have a management health insurance program and a provider health insurance program and every other employee health insurance program. So, and that becomes very hard to manage. So it's easier to create differentials in salary, and that makes sense to everyone, and that works. It's much harder to create differentials in fringe benefits. In addition, it's just hard to keep up with those other providers. So I know that we look at that, we try to understand it, but I don't know of anyone who says, well, we got to match the county or we got to match the health system. We talked about, in the first session, we talked about the cost of vacancies, and there really is a cost both to vacancies because we're not producing revenue, and that's really problematic. When we have provider vacancies, first of all, it hurts us missionally because we can't see as many patients as we want, but it also hurts us financially. So there is kind of a cost to vacancies. You're not going to see it on your financial statements, but when we think about how much to pay, and what's our philosophy, it's always, how do we make our providers, first of all, when we talk about recruitment, how do we get them here? But how do we make them less likely to quit? It's a real key question, and it's a hard conversation to have with them. I've had it with providers to say, how much less likely would you be to quit if we did this thing you wanted? And it's kind of a strange question. They've always answered, but it's something that's hard to say for sure. Well, if we do this, then we're definitely going to keep all our providers. It's not that simple, obviously. Okay, so we need to consider our administrative roles. So one of the things we're going to talk about is, the role of a provider, or the role of the provider group in our health center, and can we use that as an advantage? So again, we are not a big giant corporation. Some health centers may be very large, but still, $100 million health center is a very large health center. There are $10 billion health systems. So I would say our flexibility and our ability to structure and do things is much greater than that of health systems. So what are our administrative roles, and can we use that as retention, both as something to offer our providers, as well as, of course, getting that important provider input? So one of the other questions is, how do we pay providers differently? So our last webinar, which I think is next week, we're going to look at the schedule at the end. The last webinar that I'm doing, we're going to talk about incentive compensation in community health centers, and certainly that's a way to provide differential compensation. But what else matters? Experience. So experience seems to be the way that the market works. I'll just tell you, in my own experience working with health centers, experience is not necessarily correlated to performance and productivity. So the second question is performance. And I'm always afraid to say this is a good provider, this is a bad provider, because CMOs are notoriously poor at doing performance reviews, right? So they don't do a good job often of talking to their people. They don't do a good job of writing that performance review, giving feedback. So I know we have a lot of HR people, so kind of springing a surprise on someone related to their compensation when we haven't gone through a good performance management process is something you got to be careful with. So I've seen situations where more productive providers have been paid more. I would say the flip side as well, when we think about retention, less productive providers have not been paid more, with the philosophy being we want to retain some of our providers. If some others leave, we're okay with that. Getting direct patient feedback, obviously, customer satisfaction surveys, that sort of thing. Somewhat difficult to get. You got to remember, and we're going to talk about this in the incentive compensation presentation, you got to be able to separate out, is the comment about the health center or is it about the provider? Maybe if they speak a language by the target population, again, you know, I know places that pay more to a Spanish-speaking provider, right? That makes it, even if they only speak medical Spanish as opposed to, you know, being fully fluent in Spanish. Peer review, right? So they can look at their charts. We're going to talk, so I know some of you are saying, well, why not quality? And certainly we're going to talk about quality in the incentive compensation piece. The other thing I would tell you is the feedback that I get from providers about quality is, you're measuring my quality, but you're not doing a good measure, because a lot of times I end up seeing other providers' patients, or other providers end up seeing my patients, and so the scores get skewed when you're looking at it on a patient basis, because when we're not regularly seeing our own patients, the quality scores then don't, you know, if they're patient-based, let's say for hemoglobin, they don't often reflect, you know, my activity. That's the feedback I've gotten. Then the last bullet, sometimes what we have to do is just do a market adjustment, right? So instead of, you know, cost of living or whatever else everyone's doing, we just got to bump people up by X dollar amount to keep them current with the market. That's just a fact of life, and it's being proactive. You know, what you don't want to do is, you know, have someone submit their resignation and, you know, then offer them more money. That's probably too late, and leaves a bad taste in their mouth, and, you know, they've maybe moved on, you know, kind of mentally already, and made plans and got a better deal. So it's really kind of keeping an eye on your providers and saying, you know, are we falling behind, and do we need to make up and do a market adjustment to bring our providers to where they need to be. Okay, so I put this in kind of broken up categories to think about things. So our salary, right? Very easily compared to peers, right? And that's our biweekly steady flow of income. So really very easily understood. Sign-on bonus. So again, maybe an opportunity, and you saw what others are doing. I don't know if your feeling is that you have to match those. Oftentimes the health centers I see just say we can't match them. We need to have a signing bonus, but not something that matches. Fringe benefits we talked about, generally the same as for other employees. However, not the same potentially as some of your competitors. There would be, again, a real financial cost to that. Retention bonus. Increasingly common, we're going to look at one health center's retention bonus program. And that's something that, you know, the other good piece about it is it can be paid over time as opposed to all at once. So I know I talked about expense. I know I talked about your bottom line. What we are concerned about most in health centers is cash, right? So if we can kind of defer the cash payout and pay later, or, you know, pay more cash for staying longer, that's definitely something that we would want to do. Administrative pay, certainly paying for expenses they have just to be a doctor or paying for administrative duties, right? Are we recognizing that? And then lastly, incentive compensation, and I'll just say to kind of get you in the right mindset for the next webinar. I don't know that most of the systems that I see in health centers are truly incentive compensation systems. They're more like reward systems for good providers. And that's not the worst thing in the world, right? Because again, we want to keep our good providers. So if they don't change behavior, but they do allow us to keep our good providers, then I think it could be fair to say that the program is working. Okay, so now thinking about retention and thinking about our operations. Okay, so this is what I talked about before, the cost-benefit analysis of lowering the chances of losing a provider. This is a skill, I will tell you, on the CFO side that we haven't mastered yet, right? But you could do an equation that said, if we are able to lower our provider turnover, our provider leaving, our provider vacancy rate, we could model, let's say it turns over at 25% a year, we could model what the financial impact would be if it turned over at only 15% a year. Now, again, the part we can't do is say, well, what could we do to guarantee that it would decrease that 10%? And the answer is we can't guarantee it. But I think, especially for the large health centers, where there's more turnover and it's kind of more predictable, you should do this analysis. For a smaller health center, you already know that a provider leaving or a vacancy has a much bigger impact on you, right? If you've got 4 total providers and 1 leaves, that has a big impact on the organization, on access, on everything, as opposed to an organization that had 40 providers and had 1 leave. Much lower impact. What I see is, remember when I said keeping good providers, losing our star providers has an annuity effect, right? We kind of pay for it every year. That they are often not replaced by someone as good. And I'm going to add in quality. I'm going to add in participating with the organization, in addition to productivity. So really, keeping stars, you can't say, well, we lost our best provider, so we're going to replace them with a really good provider. It just doesn't work like that, right? There's only so much you can know about new providers. And superstars, not all providers, as you know, perform the same, so superstars are rare. The MA is something, MA turnover. So if you're using RNs or LVNs, that's great. But I think we need to think about their turnover, because that's a position with higher turnover. And there, I'll say, once again, we want to keep our stars. What providers tell me is, if I have, I'm going to say a good MA, not a great MA, a good MA who understands what I want and understands how to do their job, when they leave, that sets the team back by 6 months. To get someone in there, to get them at least to understand the provider style takes 6 months. So they're kind of less productive, less happy. So we need to think about this on the MA side. In smaller communities, again, smaller health center, bigger impact. What they also tell me is, if they move to another organization in town, the patients follow them. So you've got this double whammy of losing, the provider and the productivity and the continuity, but also losing patients, which is clearly a problem. It's not always easy to recruit patients, and new patients are harder to serve than established patients. So really a much greater impact at a smaller health center, or even at a large health center that might have multiple sites, some of which are in smaller communities. So this is more about how big is the area that the clinic is in, as opposed to how big is the health center itself. Okay, so one of the things that successful health centers have done is kind of branded themselves. You know, do we have a brand? Do we serve a specific population? You know, so generally, yes, we serve poor people, or, you know, and uninsured and underinsured and people below 200% of the federal poverty limit, but we might be able to break that down even more. Faith-based organizations often look for faith-based providers. Maybe you're a training site and providers want to be a part of that. Delivering higher quality of care. Who wouldn't want to be, what provider wouldn't want to be in an organization with high quality care, right? That we can show, that we can prove. I think if you've got the numbers and you got the data, that's potentially a recruitment strategy or a branding strategy, right? We do high quality care. Chronic disease management experts, right? We're really good at managing diabetes and hypertension. So we've already got protocols, we can help you out. And, you know, we help people live longer. You know, helps attract missional providers. Then we might also say that the CHC is a good place to work. So, and keep in mind, a provider who's worked somewhere else already knows what that somewhere else is like. So I would say generally, and I'm not sure this is a strategy, but generally it's more important to accentuate your positive than your competitors for staff's negative, because oftentimes whoever you're trying to recruit is familiar with their negative. So certainly saying we're a good place to work because we're mission driven with a high quality of care. You know, to even say we see everyone regardless of ability to pay. It's a very strong statement to make, and, you know, something that's quite, I'm going to say, not only unusual in healthcare, unusual in American business, right? Who, you know, places where we, the business isn't looking on how much they're going to get paid. The provider's not on their own. Certainly something for anyone coming out of private practice. Providers hate paperwork. Providers hate administrative work. So to say you're not on the own, number one, you're part of a team of other clinicians who can help you out, as well as support staff that can help you out. We have comprehensive care. You know, if you have a pregnant woman without a dentist, you know, we either provide dental care, you know, it's very important, dental care during the pregnancy. So we provide dental care, or we arrange for it. That's not even a question that they can get it. And again, if many of your patients are seeing behavioral health, heck, we might have even incorporated a behaviorist into our primary care team, right? So they're just there. No hospital calls, so you don't have to get phone calls. You don't have to go to the hospital in the middle of the night. No human resources role. I know we have a lot of HR people. You guys are good at what you do. The rest of us are not good at HR and don't like HR. So if you take that away from people, that's a good thing generally. Less paperwork, and I put hopefully. So certainly one of your questions is, do we have enough support staff that are taking away that paperwork? And to the extent that we can take it away from our providers, we make them happy. So first, the part-time provider I talked about already. And then the next one, I said alternate, maybe if it makes it easier for you to understand, alternative schedules. So this, I know, is not the best. This is an example for a full-time provider. So instead of working 8 5-hour days, there might be providers who prefer to work 4 10-hour days. Now, again, if you're mixing 8 times 5s and 4 times 10s in the same clinic, it makes things a little more complicated operationally, but some providers love it. Some providers even like the longer clinical sessions because they say I can really get into a groove, or if I had one patient that backed up the session, then I've got more time to catch up. So it's something to think about, and those providers actually tend to be more productive. So it also works better from the financial and operational perspective. Might include a residency program. You want to learn about taking care of people. This is what I always hear from the program directors, affiliated with the teaching program. Health center is a great place to learn, right? It's not just coughs and colds. You're going to learn lots of things about patients and their needs, and really get a broad base of experience. So number one, that helps getting providers who might be interested in that, as well as those participating, maybe we can get them hooked on community-based medicine, right? Show this is an environment you might want to work in. And then, how early in the pipeline can we incentivize residents? Be careful on that one, is what I'd say. Okay. So here's our support staff. And to me, I know PCMH is, theoretically about population health or saving the world or improving quality. From a very operational perspective, PCMH is about taking work away from the providers and giving it to someone, and I'll say from the financial perspective, someone who makes less. So you get a financial win, but maybe for someone more appropriate to do those things. So, you hear the concept of everyone operating at the top of their license. For a provider, from their perspective, less time doing stuff that you don't need to have gone to medical school or your residency or have their training. So a lot of these things we're building the care teams around, and many of you are doing that, and the providers tend to be happier because these things, number one, get done better. Many of them have task lists in their EHR that are way behind and they never get done, so they find that very frustrating. So to the extent they have the support team, they're happier. And then maybe variety, putting different activities in. One of the things I would say that I'm seeing emerging is, telehealth, e-consults. So to me, it, number one, gives a different modality for providers potentially to serve patients. Number two, it gives more access. So I'd say that I know there's a lot with reimbursement and figuring out what we can get paid for, but I think it's something providers have gone along with, and I don't want to say it's a relatively newer thing, but providers seem to be pleased when we put this in. Making your EHR more usable. So the question is, if you ask your providers, how do you like the EHR? And they respond, we have the world's worst EHR. That is a grinding point of dissatisfaction. So you need to look if there's a version update, there's templates you can do, if the training wasn't right in the beginning, or even if you need to replace that EHR. It costs you money having a bad EHR that your providers hate. It costs you money every day. And I know that there is much pain and suffering in changing an EHR. It still might be worth it. And I've seen health centers take that plunge. Okay. So again, some of those advantages specifically over the health system or more corporate is that we can do that full scope of family medicine. So I would say this, if you work for a health system, one of the things you're expected to do is feed the beast. So those diabetics, many of which you feel that you can handle yourself, right? And it's better if you handle yourself. There may be more pressure in the health system to refer them, let's say, to an endocrinologist, right? So might be an advantage to say, hey, we can serve the patient the right way, and hey, we think you're important and we think you can handle this. More flexibility in the schedule, as I talked about. I put an asterisk on more input in decision making in health centers, because I've seen health centers where the providers have no voice, and quite honestly, the CMO doesn't listen to them. So that could be an advantage if you make it happen. And while visit productivity is hard, RVU productivity is even harder. So those are things that potentially you can say, hey, we know what it's like out there, and here's what we've got. Okay, so thinking about the onboarding, making sure that they get the appropriate EHR training. Allowing them, so this was real interesting, I hadn't thought of this, allowing them to shadow the front desk, to shadow the billing department. If there's a call center, to let them sit in and listen on some calls, it really gives a lot of perspective rather than throwing them in. So I hadn't thought of that. I think that's a fabulous idea. Seeing patients with established providers, especially if they're brand new, right, to learn, one thing they'll learn in residency is how to be productive. Certainly starting out with a reduced schedule, and then providers straight out of residency. So yeah, experienced providers, but what I hear from health centers everywhere is a good support staff. A good clinic manager or a good flow nurse can make up for a lot of problems. So it's a great place to start out to say, we're gonna, at some of our tougher sites, I don't want to say we're gonna put our tougher providers, but certainly our new providers, we're gonna try to put them at a site where they have good support to make sure we start out okay. Mentoring, certainly, again, getting those experienced providers with our newer providers. And then, as I talked earlier about that ratio, making sure that if the physician is spending a lot of time on NP supervision, that we're somehow recognizing that and maybe not expecting the same level of productivity. Okay, giving the CMO time to be the CMO. I see many health centers, large health centers where the CMO spends 1 day a week as administration. That's just not enough. Thinking about other physicians, making them EHR guru. They love that. Defining total hours and clinical hours expectations in the beginning, right, in the contract. A retention bonus, which I'm going to show as my last slide, and then retaining those key support staff. So here's an example of one health center. They say, if you come in and we'll sign a 3-year contract, if you make it 1 year, we'll pay you $5,000. If you make it 2 years, we'll pay you $15,000. So we'll make up, right, that amount. And then if you last 3 years, we'll make it an average of $20,000. So you kind of get paid for the years before. So it's real nice. It's paid 90 days, so that's pretty timely, gives you time to close your books. And remember when I talked about part-time providers, you must be at least half-time, and half-time is pretty darn low. I had some back and forth with the CEO talking about that. I'd prefer that it be higher, but this is their program. So with that, we've left a little time at the end for questions. Suzanne, are you managing that process?
Hi, Curt. Yes. If you have any questions, go ahead and put them in the questions box, and we would be happy to answer them. Looks like we don't have any questions now. Let me see. It looks like somebody raised their hand. If you want to go ahead and put that question, if you had a question, if you raise your hand and you want to ask a question, certainly put that in the questions box, and we will answer that there for you. Okay, while we wait for questions to come in, I just wanted to make you guys aware of the remainder of this compensation series. As Curt mentioned, he will be back next Wednesday at 1 p.m. Eastern and talking about incentive compensation. We also have 2 others in this series on June 5th and June 12th. So we hope you all would join us not only for next week with Curt's last session with us on the series, and then the other 2 as well. So I do see a comment. One just came in. So let me read it up for you, Curt. Okay, and this is just a comment, actually. It just says, we allow 0.8 FTE medical providers to receive health insurance at the same cost as for full-time 1.0 FTE providers.
Okay, so again, it's recognizing, yeah. So so that's a great point. So while I'd say on the flip side, we said we've got to accommodate partial FTE providers. If there are ways to incentivize non-full-time provider, if there's a way to incentivize to get this as close to 1 FTE as we can, so they said 0.8, which is 4 days a week, yeah, then we'll give you health insurance. I'm assuming if you're only 3 days a week, you don't get health insurance. So, if we had some differential, that might be a way, because I'll tell you, operationally on the back end, it's really a lot better if we can have full-time providers.
Great. Thanks so much for commenting on that comment. It looks like we have someone raising their hand, and if you have a question or something that you want to just a comment as this last one, if you will actually just put it in the questions box, then we will go ahead and read it out. Okay. I have another comment. It says, I like what you were saying, but how do you get a CEO to see the importance of what you were saying about salary and benefits for all positions, not just providers? Granted, providers are crucial, as you mentioned. What about the MAs who support the staff as well being critical?
Okay, so what I would say is I would want to avoid this thing, and I've seen it happen and get out of control. Every person, benefits the bottom line. So how much is a biller worth? How much is a good front desk person worth? Not that it's not important to retain people. So I would focus, honestly, the way I would get the CEO to recognize it, I would think of the care team, because I'll tell you again, as a financial person, that's where revenue starts from. Start with the providers, and then go with the support staff, the MAs and the nurses. And I'd say we want provider retention first, and then second, we want retention of that core team. And I don't want to say we don't care about everyone else, but I'd say that it really has an impact when we turn them over, and then when we turn over the care team, it worsens provider retention. So I don't know your CEO, but the best I could say is narrow your focus.
Great. Thanks for that again. We have one more that came in. It says, you mentioned having a provider shadow the front desk, billing, or call center folks. How much time do you suggest for this during onboarding?
That's a great question, because I'm going to have to make up this answer. So, so the short answer is, you need to spend about 5 minutes at the front desk to understand what's going on there and really get an appreciation for how chaotic and how difficult it is. So I don't think necessarily you have to spend a lot of time there. What you're going to do if you spend more time. So I would say, even if you had, 2 sessions, billing, a few hours in billing, because it's a little less interesting. And then, just a few hours. Most phone systems have the ability, and there's this disclaimer where you're actually listening into the calls and you're hearing the types of calls that come in. So I don't think it's a ton of time. I would only say if kind of the triage or not triage process isn't working, then it might make sense to have a little more time at the front desk. And this is just my impression. I didn't get that answer from the health center. So maybe that's even something I can ask and bring up at the next call.
Okay, and we have, I know it right at time, but we have 2 questions about contracts and templates. So one person asked if you have a sample template or productivity contract. I know you're going to probably talk about that during incentive compensation. And also, do you have a template for a good onboarding process as well?
Oh boy, do I have a template? No, so I guess the way we'd have to handle this is my email is here. I don't have a template. I have stuff that people have shared with me. And if you send me an email, I can then ask them, if I can share their stuff with you. One of the questions is also how well is it documented? I'm pretty sure there are contracts out there, so that one might be easier. How well someone has done in writing down their onboarding process or having a document, I'm not sure, but email me and I'll see what I've got.
Great. Thanks so much. And thanks to all the people who asked questions. And I know it's great to get some, as we dive into this and we think about things and questions come up. So thanks everybody for asking those questions. And we also, as we wrap up today, I know we're a couple minutes over time and I apologize for that. Just wanted to let you guys know that the recorded webinars and also the slides for each session are archived on our website at chcworkforce.org. And so you can go to our webinar series, or you can search compensation series at the top, and it should take you to those archived series with the recordings, the YouTube recordings, as well as the handout. So with that, thanks everybody for joining us today. Thank you so much for Curt Degenfelder for being on, and we will talk to you next week on the 29th at 1 p.m. Eastern. Thanks, everybody. Have a great afternoon. Take care.